I would like to introduce the next presenters. And Albert Wu and Cheryl Connors, I've known for a long time. They have developed a program that is an important program. It's at the Johns Hopkins Medical Institutions and Hospital. It's called the RISE program, Resilience in Stressful Events. It is a staff support program. It has elements that I think you will resonate with, you'll find familiar. Can it be said that hospitals and healthcare facilities are sometimes stressful places? Yeah. Taking care of other people. The first physician-in-chief at Johns Hopkins Hospital, Sir William Osler, said, "It is necessary to develop a sense of equanimity because caring for people is stressful and takes a toll." And the RISE program is a staff support program to assist people, multidisciplinary in nature. So help me welcome the folks from RISE.
Good morning. Thank you all for having us. I am Cheryl Connors. I'm a patient safety specialist with the Armstrong Institute for Safety and Quality, and I brought my dear friend, Dr. Albert Wu.
Albert Wu, I'm an internist at Johns Hopkins. I'm very pleased to be here with Dr. Cheryl Connors as of about 1 week ago. And we're very happy to be here. We work in healthcare. How many of you work in healthcare? Wow. We think we have a lot in common with you because, in fact, we are also students of George Everly. But we've never been to your meeting, and we've never really known so much about the ICISF. Did I get that right? Did I get those initials right? But listening to George and looking around the room and browsing in the resource room next door, I think we have a great deal in common. And I think we're here to learn as much as we are to tell you a little bit about what we have been doing. So I did see heads nodding when George mentioned that RISE was a staff support program. I don't think people think most of the time. Have any of you been a patient or had a family member who was a patient in the last year or two? Anyone? So most of the time when you're there, I think you do not spend your time thinking about how stressful this environment is for your nurse or for your doctor. But in fact, that is really true. Healthcare places, hospitals, emergency rooms can be very difficult and potentially traumatic places. They're really hazardous workplaces for healthcare workers. And Cheryl, do you want to tell a story about Johns Hopkins?
So back in 2001, we had a young patient named Josie King. Has anyone ever heard the Josie King story before? Well, I'm going to tell you a little bit about it. It's a very personal story for me. Josie was an 18-month-old baby, and she was admitted to Johns Hopkins because she was severely burned from a bathtub accident at home. And she was admitted to our ICU, our pediatric ICU. And so she was receiving excellent care. She had been there for about 2 weeks, and because she was making such great progress, what happened was she then transitioned out of the pediatric ICU and came to my unit, which was the pediatric intermediate care unit. So for those of you who are in healthcare, you might be familiar with transitions of care, and when that transition happens, essentially the team members change, there's new people in place to help coordinate the care, And so, for those of you who are not familiar with burn care, it requires a lot of healthcare providers to manage the patient. And so Josie came to my unit, and we were taking care of her, and she was still making good progress. And so we were actually at the point where we were even talking about her discharge. Until one day, she started to show some signs and symptoms that maybe she wasn't doing as well as we all thought. Josie proceeded to code, and she died. So in 2001, we were just on the heels of patient safety. So in 1999, the Institute of Medicine published an article that said, hey public, healthcare is really not that safe. In fact, it's quite dangerous. Up to 98,000 patients die every year as a result of medical error. And so Hopkins, recognizing that this was the case, they quickly did an investigation, and they quickly admitted that Josie's death was preventable. We failed this family for a variety of reasons. What the missed opportunity was that Hopkins did not recognize how to take care of the people who were taking care of Josie. And so out of perhaps fear of litigation, maybe just not knowing, because this was new territory for us, this was a very public event, the administration came to all of the healthcare providers involved and said, don't talk about this. Don't talk about it with your colleagues. Don't talk about it with your friends or family. Don't talk about this with anyone. And so you can imagine the types of feelings that triggered in the people taking care of this baby. We were also traumatized, we were grieving, and now we were confused and scared and feeling maybe responsible and guilty, and we didn't have a clear picture as to what happened. Well, I can tell you what happened in the year to follow is I watched some really amazing healthcare providers leave my unit, leave my organization, and one even left the profession. And it was devastating. And so it wasn't until 6 years later that our legal department was prompted to go ahead and reopen this case, where we were able to discover new clinical findings. And it was at the same time that a book was being published by her mom. One of our great colleagues, Dr. Peter Pronovost, was publishing a book. And so we were able to identify these new clinical findings, but we were also able to recognize that it's really important to take care of the caregivers, and that we lost really great people because we failed in that aspect. And so it was at that point that our leadership said, we are committed to putting in place a program, and we need some really cool people like Dr. Albert Wu and Dr. Cheryl Connors to help us do that. So they said, go forward and create something so this never happens again, because we know healthcare is stressful. We know people are human and things are going to happen. And what we found is that even the most resilient healthcare providers, they fall down sometimes. And some of the body armor that our colleagues put on is not equipped with all of the great coping strategies that Dr. George Everly shared with us, but some of it is very dysfunctional. And so it was at that time that we had decided to create what we call RISE. For those of you who've experienced healthcare in any way, you likely know that it is a high-risk environment. And what has changed over the last 20 years, because it's really been almost 20 years since Josie died, and healthcare was complex then, is that the patients that were in the ICUs in 2001, they're now on regular general med-surg floors. And the patients that used to be admitted to the hospital, they're getting cared for at home. And so we've come a long way, and there's additional demands that are placed on healthcare providers, like the electronic health record, We have a lot of workplace violence issues that we're facing, especially in the last 5 years, where patients and families are attacking staff. And so we know our staff need support. We have people's lives in our hands. It's a huge responsibility. And we are committed to creating the healthiest people possible so that if you're one of them, that you feel healthy and well, and if you are a patient, that you can be cared for by a healthy and well individual.
So on top of that, it's very easy to be a doctor or a nurse. When you go home at Thanksgiving, when you're training and your aunt says, "What are you doing?" You say, "Oh, I'm in nursing school," or "I'm in medical school." And the people at the table say, "Oh, isn't that wonderful? My niece is a nurse. My brother-in-law is a doctor." That's wonderful. People go into healthcare because they feel like they can help people and really aim to do that. And they're part of a vast conspiracy that they share with patients. And that is when you go in to get healthcare, you're going to go and have a procedure perhaps. They're going to cut you open and leave you on the table for a little while and then rearrange things, and then everything will be fine. Everything will be fine, and everyone would like to believe that that's the case, except frequently it is not. And that adds an additional stress to these healthcare workers who believe that they can do good things, and when things go wrong, they often believe it's their fault, even when it's not. A little while ago, a patient died unexpectedly during a procedure. It turns out she could not be intubated for a very complicated set of reasons. And in the end, she died because of that during a procedure with anesthesiologists and surgeons all around. And we went to talk to this group. People were distraught. People were crying. Senior anesthesiologists and junior nurses and everyone around the table. And one of the anesthesiologists said, "Well, I'm the most junior person on the team, so it must have been something that I did wrong." And sitting there, there was no reason for us to believe that she had done anything wrong, but she truly believed that she had been to blame, and she burst into tears. When something stressful occurs, what we have on this slide, I don't really even need to go into in any detail because this is your business. This is where you guys live. When there is a mistake or when there is a terrible, disappointing surprise, people experience an acute stress reaction. If that persists, and in particular if they are not supported, this can develop into a chronic stress response. And healthcare workers, importantly, can be impaired in their ability to be empathetic, to be compassionate, to be attentive even. And there's evidence now that healthcare workers who are in this state make more mistakes, so there's a vicious circle. There's also a vicious circle for everyone. So the organization, in fact, has a lot at stake. When staff are stressed, which is all the time, and they are unsupported, this is terrible for morale. There is, in fact, now, and I don't know if this has reached sort of the lay public, but there is a real epidemic of clinician burnout in healthcare. In many surveys, 50% of physicians and 40% of nurses will report symptoms of burnout. And this is something that's definitely not good for them and really definitely not good for their patients. This leads to more turnover, more extra shifts, more overtime, and even more hazardous work environment for them, but also for patients. People leave, and this, in fact, stresses their managers, and the cycle repeats. So, in response to this, in about 2009 or 2010, leaders at Johns Hopkins Hospital began to think about how can we do better? We obviously failed Josie's nurses and doctors. What can we do to do better by them? How can we support our own workers, the caregivers themselves, so that they can do a better job taking care of patients?
So before we had the pleasure of meeting Dr. George Everly, we created what we thought would be a great mission for this program. And so how we created that was we asked our healthcare providers, if there was a program or resource available to you, what would you want it to look like? And they told us they wanted it to be confidential. They told us they wanted to be without judgment. They told us they wanted it to be from somebody who could understand and relate to what they were going through. They told us they wanted it to be available to them 24 hours a day, 7 days a week, because we are a 24/7 operation. And they told us some of their stories. And so we put together our mission statement for our program based off of what our healthcare colleagues told us, because this type of program, out of all the resources that we had available at our fingertips, this did not exist. And it was a difference between our colleagues getting no support and getting mental health care support. And they were saying, I don't think I need a licensed mental health care provider. I really just need a safe space. I need somebody who I can talk to and share my experience with. That's what I really, really need. So as we were taking the next steps and identifying some really great people who are on the peer responder team, and I'd like to just acknowledge and thank them for the work that they do today, because it is a volunteer program. We were trying to seek out what was the appropriate training to prepare us to be able to provide this type of service. And that's when we discovered Dr. George Everly.
The confidential piece of this is very important. And I believe that many of you encounter this in the work that you do. Doctors and nurses basically never ask for help. They feel like they are there it's the patient. This is about the patient. It's not about me. I need to keep a stiff upper lip. I've got to support my patient. And many of them even perceive asking for help as a sign of weakness. If you're a firefighter or a cop or a soldier, I believe that, I've never been in one of those professions, but I believe that the environment and the culture is likely to be very, very similar. We assembled a group of volunteers. We felt it was important that these volunteers were peers, because many of the healthcare workers we talked to said, I don't want to talk to a counselor. I don't need therapy. I want to talk to someone who understands what I do and what I'm going through. I need someone who does this kind of work. So we assembled a very multidisciplinary group of different kinds of healthcare workers, mostly nurses as it turned out, but social workers, physicians, techs, an EMT, and very importantly, hospital chaplains. And these are all people who we found who were just normally the people who people go to talk to when they have a problem. They know that they can trust them. They know that they will keep things confidential. And we didn't want to train therapists. We figured that we wanted to just provide enough support so that people could get on to the next thing. We realized that we needed psychological first aid. So we assembled a group, and then we realized we needed to train them to do something. And we realized that we were not trained in this entire field. We began to read a little bit, and in fact, we had some people who were, for example, psychiatric social workers. We had some therapist people on our team, but we realized we needed psychological first aid. We knew, since we were in medicine, we knew about regular first aid as sort of a first step. If I were to fall off this stage, I think George would probably catch me before I hit the ground and hoist me into the air, and then maybe pump his fist. But if I fell, you know who I'm talking about. But if I fell and injured my leg, I'd hope he would provide a little first aid. I hope he wouldn't attempt any surgery. I would need first aid and maybe a little bit of support. But if I needed more, I could get on to more advanced levels of care. And we realized that this is what we needed too. We were just there to provide support. There were plenty of resources. There are psychiatrists and psychologists and staff support programs, which unfortunately are only really running during business hours. We could refer people on eventually to more care, and even occasionally, in a few % of cases, to actual medical care. We were very fortunate at that moment to realize that there was a resource actually at Johns Hopkins, which was rapid PFA. We contacted George, and he very generously offered that he was doing training. In fact, he was doing training all the time. It was mostly not for healthcare workers, but in fact, he offered to train us all for free to meet with us and give us advice. We were very happy to take advantage of this, and in the end, we wound up adapting rapid PFA really only slightly to meet the needs of they're not clients, they're not patients, but the people we're supporting. Certainly reflective listening was something, perhaps 70 or 80% of what we wanted to do. We realized that it was important when there are healthcare crises in the hospital to come in and be a calming influence. We, particularly because doctors and nurses and others in these situations feel like they might be to blame, we felt it was very important that we be as non-judgmental as possible. This may not be a problem if you're supporting firefighters, but in this case it was crucial. Empathy, I think, is something which underlies all of these kinds of support. Another problem is, even though under rapid you might be prioritizing and intervening, we as healthcare workers are designed, nurses in particular perhaps, are built to try to fix problems. But we had to realize that we needed to unlearn that instinct and to really just provide support. We could not, in the 30 minutes or 60 minutes that we talked to people, we couldn't fix their problems, and we couldn't fix the patient's problem that was in front of them. And we actually stopped short of doing a lot of referring and disposing. We wanted to provide resources. We were informed by our hospital legal department that we were actually not providers. We were really more good Samaritans than anything, and we should not be officially making referrals to other providers.
So in an effort to evaluate the work that we were doing, we learned that it was not helpful or even maybe the right thing to do to ask somebody that we met with who called us and because we promised them a confidential, safe space, to ask them, hey, how do you think that went? How do you feel now? How did we do? We strive for 5. So we have since practiced our recipe that Albert just shared with you that was adapted from the RAPID PFA. We have gotten fairly good at the work that we do, and we have come up with some very creative ways to evaluate our program. One way is we did a cost-benefit analysis, and this is the business case because we really want to encourage other healthcare organizations to implement similar programs. And we have had actually many calls from the local EMT department, fire department, and other types of organizations outside of healthcare to inquire about this because this work can certainly be translatable into other environments. What we learned from our cost-benefit analysis is that we can save a ton of money if every time an event happens, someone calls to get support. So essentially reversing that ugly diagram that Albert showed you, that vicious cycle.
So the funny thing is that in healthcare, you can probably do well by doing good in this case. If you need to, every time there's a really serious incident, healthcare workers, doctors and nurses are likely to be traumatized, take time off, take extra time off, and maybe even leave the profession. And replacing a nurse, on average, for a big hospital might cost $50,000 or $100,000. Replacing an ICU nurse might be a couple $100,000. Replacing a physician or even a surgeon might be $500,000 to recruit and replace that person. And so every time, we calculated, a nurse feels disturbed enough to call RISE, and we respond, Johns Hopkins Hospital saves $22,000 in deferred risk for time off or even leaving work. We didn't bother to calculate for physicians, but this was more than a back-of-the-envelope calculation and has actually been convincing to other institutions, which Cheryl will mention in a minute.
Also, we learned from our implementation process, and so we reflected on all the steps we took to get ourselves off the ground and what it looked like once we launched a program and how the organization responded to it. And so we have a publication to share on that would motivate other organizations to adopt similar programs. This was recently endorsed by the Joint Commission. I'm sure those of you in healthcare are familiar with the Joint Commission, but it's our regulatory body. They came and spent a day with us. It scared me. I thought we were doing something wrong, and they said, we commend you, and we think that you have a model program that should be used as a leading practice model, and we would like to endorse other health care organizations in adopting your model. And so they wrote a publication on that to support our implementation process and our model. We also did a pilot in the Department of Pediatrics. That's where we started the program, partially because that's where our story began with Josie King, and we had great leadership support from that department. So before we expanded to our huge 1,200-bed campus, we thought we would trial it in a 200-bed part of the hospital and iron out the kinks. And so we published a great article on that. We're in the process of doing 2 studies that are connecting the work of RISE to resilience and burnout and satisfaction, primarily with the people who are activating the program. So we're finding that it's our nurse leaders. No surprise, they make up a huge portion of our population, they are activating the program. They're not using it themselves so much, but they're saying, I have to take care of my people, and you are my avenue to do that. So we are evaluating their resilience and burnout and satisfaction in relationship to the use of our program, as well as the nurses who are our main users. So we have a large, diverse group of people that use the program, but again, nurses are one of the most frequent. So we are studying that as well, and we're excited to share our findings with you. 2 years after we implemented RISE, our local Maryland Patient Safety Center found out about us. They had a request for proposal out, and we replied to it. And they quickly reached out and said, we want to partner with you because we want to help you get the RISE program in our region, in all of our hospitals. And they primarily cover the Delmarva area, so that was our target focus. What happened very quickly after we created the curriculum, so it's a 2-day program. Day 1 is targeted for leadership, and it's just getting a shared mental model for the organization as to why this is important and what is required on leadership's behalf to start a program, and then most importantly, sustain a program, and how will they support their peer supporters. And then day 2 is the peer responder training that we created for healthcare workers, partially adopted from the rapid psychological first aid training. And we are really proud to say that we have, since 2014, implemented RISE in all of the organizations listed, and that includes one international location, the Saudi National Guard.
Which is not in the Delmarva area.
That was the surprise, was that many of the organizations that reached out early on were not in the Delmarva area. So we have been on the road doing quite a bit of work.
We're fortunate that, it's odd. Some of you may experience this some of the time too, but there are enough crises in the world that you may find that the work that you do is suddenly popular, and people on the street even understand what you're doing. This has actually been the case for us. About 2 decades ago, I described the problem of healthcare workers who are traumatized by the mistakes that they make, or by being around when patients are harmed by healthcare. We describe these people as second victims of the same incidents that harm patients. And this concept, the idea, and really the realization that burnout is such a rampant problem in healthcare, and the fact that now the Joint Commission and others are beginning to discuss the real need for staff support, leads us to really be optimistic that what we are doing has importance for more than just Johns Hopkins Hospital, but for healthcare organizations around the country and even around the world. There are similar programs, or at least related programs, now in countries all over the world, and in many ways, this work reflects well on the work that you are all doing here. We certainly wouldn't venture into providing support for firefighters, but we feel like we can take care of our own, and that perhaps we're onto something.
I just want to say a special thanks to Albert, because he's also part of the reason why we're here. Because Albert identified his own experiences all the way back in the 80s and was willing to write about them and share about what it felt like to be a second victim and witness other people in that same category. I think that we have then become aware of the problem and the magnitude of the problem and the need for the intervention. So thank you for leading the work.
And Dr. Connors, of course, really runs our program. I would say that she's the heart of our RISE program at Hopkins and perhaps the den mother for all of the programs that are springing up around the country. So I certainly owe her a great debt of thanks. Thanks again to George and to all of you for the work that you've done that has accumulated and helped us go forward. Thanks.